Hello, everyone. Welcome. Just getting started here. We'll take a couple minutes to let everyone enter in the Zoom room, and then we'll get started. Please feel free to unmute yourself and introduce yourself, or pop a note in the chat letting us know where you're calling or zooming in from, what your role is in long-term care. We'll just get started in a couple of minutes here, but thanks for being with us.
Hello, I'm Rose.
Hi, Rose. Welcome. Where do you work?
I work at the Priory in Victoria.
Oh, wonderful. What's your role there?
I'm an RN.
Nice. Well, welcome. Thank you for coming.
Thank you for having me.
Oh, welcome, Duncan. So we'll just give everyone a couple of minutes to join here, and then we'll get going, but feel free to introduce yourself. Hi, Rosita. Thanks for coming. Hi, Jerry. Oh, hi, David Clinton Baker. Welcome, everyone. Don't worry, Duncan. I have a loud child in the background, too. Hopefully he doesn't say anything while I say anything. All right, I'm sure people will trickle in, but we'll get started. So welcome, everyone. Thank you for being here today. This to our Victoria South Island LTCI Learning Series event on dermatology. I'm Jessica, the Victoria South Island LTCI Program Manager. I'd like to take a moment first off to welcome you to this Learning Series event and say that it is with great respect and appreciation that I am speaking to you today on this very fall, beautiful day after Halloween from the traditional and ancestral territories of the Sauk Nation, where I'm very lucky to work and live. So just a couple of housekeeping items. So this is a CME event. A certificate will be emailed to you within a week. There will be an evaluation at the end, so please take a moment to complete it, as your feedback is very important to us. This event today will be recorded and placed on our website, so please refer your colleagues if they might be interested in watching. If you have questions throughout the evening, please unmute yourself and ask away. We love these events to be interactive. This presentation will be focusing on adverse drug reactions as well as skin cancers in the elderly. So if you can kind of restrict those questions to those sort of topics throughout the event. If you have further questions beyond the topics of this presentation, our presenter, Matt, would be happy to connect with you after the event. So last but not least, I'd like to introduce our presenter for this evening. Dr. Matthew Galas is a highly qualified physician with a diverse background in dermatology and family medicine. He completed his medical education at UBC and later pursued his residency in family medicine at the University of Calgary. During his training, he had a strong focus on dermatology electives through UBC, allowing him to develop expertise in this field. He furthered his education by obtaining his diploma in dermatology from Cardiff, enhancing his knowledge and skills in skin health. He is also certified in dermoscopy, a valuable tool for dermatological conditions. Currently, he practices a blend of medical and cosmetic dermatology at Jubilee Center Physicians and Ageless Living, offering a wide range of care services from managing conditions like acne and psoriasis to diagnosing and treating skin cancer. So without further ado, please welcome Dr. Galas.
Thank you very much, Jessica. Thank you everyone for coming this evening here. Sorry about the little delay that we had in the presentation, but really happy you all can make it tonight. So my presentation, I know dermatology, it's such a large breadth, and often in medical school, a lot of the curriculums have 1 week, some curriculums even upwards of 2 weeks, and they try to compact everything into that, which leaves a lot of physicians, nurses, and other allied healthcare individuals to learn on the run or through self-guided learning or through residency training. So what I'd like to do today is focus on a couple topics just because this is such a large specialty here. The two topics I'm focusing on here today are adverse drug reactions, probably a really good foundation for dermatology here, as well as skin cancers, just given the prevalence in the elderly population that we encounter day to day, and quite a complicated diagnosis to make sometimes, just seeing a simple IK versus is this an SCC, and making the diagnosis there. But yeah, so I'll focus today in possible future presentations. We can expand more into different topics as well here, infections and other ones. But yeah, so I'll just get the presentation rolling here. And if you guys have a burning question in the presentation, I'm happy to answer that, or at the end we can answer some questions there. And I've got my email address up here if you want to jot it down right now. galas@alumni.ubc.ca. I'll be happy to get back to your questions here. Might take a little bit of time, but I'm happy to do so. So let's get this presentation rolling here. Oh, actually, probably just before I begin, I don't have any disclosures here to make. No endorsements from any pharmaceuticals or no personal to gain profits from this presentation today. So first off, in the elderly, we do have a lot of skin changes that do happen. With that loss of elasticity, collagen, our fibroblasts are just not as functional, and a lot of pigmentary changes. And there's different factors. We've got intrinsic and extrinsic factors that lead to these various changes that do lead to more susceptibility and also a change in presentation for skin. One of the worst, of course, is the photo damage, or ultraviolet A and B radiation. Both create significant damage here to the skin that do lead to these changes. Other things that do happen are melanocytes. They're just not as effective. They're just not producing the melanin to the same extent. They're not transferring the melanin in those melanosomes to the surrounding cells here for that support, resulting in less ultraviolet radiation being absorbed. And then we've got more damage that's happening to the DNA from the surrounding cells there in the epidermis and surrounding tissue there. And now just to break down the intrinsic versus extrinsic aging, what's going on. So I already mentioned ultraviolet light. Extrinsic aging is an example of ultraviolet light. So anything that is thrown to us from our outside environment. That can be other things. That could be topical medications. So for example, a factor in extrinsic aging would be if we're applying corticosteroids. Frequent corticosteroid use, regardless of whatever the strength is, hydrocortisone all the way to clobetasol, we're going to have changes to that, to the skin itself. You're going to have more telangiectasia. You're going to be having thinning of the skin, and you're just getting a general loss of that structure. Other extrinsic aging factors that could happen as the person throughout life was exposed to their environment can be anything from their occupational exposures. So did the person work in construction? Were they exposed to more tar, making them more susceptible to damage that would make them a little bit more prone to squamous cell carcinomas? So there's a myriad of different things in terms of the extrinsic aging that leads to these changes. And one of the common ones you often see also in the elderly, I know I'm focusing a little bit more on the drug reactions, the adverse drug reactions, as well as the skin cancers, but a common one that you get from a lot of the elderly population is bruises. All the time, you just get those ecchymoses on their forearms, on their hands, and that would be a good example of a combination of intrinsic plus extrinsic aging. Extrinsic aging, the thinning of the skin due to the ultraviolet light, a possible corticosteroid use, loss intrinsic, also the free radical damage that's happened. So different things impact that. And we just move to the next one here. So just going to the basic cellular level, so our stratum corneum, essentially it's actually becoming the same thickness, but the fatty acid loss is quite key. So you'll note a lot of elderly population will say they have itchy, they have dry skin. It's the fatty acids play a huge factor in that. The dermis. Dermis is where we're getting a lot of our structure from that collagen, and it's 1/3 of the thickness at age 80 compared to when the person was 18. Now, what different things can we do to preserve that dermal thickness? Everything from the intrinsic to extrinsic factors. So reducing the exposure to ultraviolet light. Can we reverse it? Up to a point, and that would be a little bit more through different treatments that we can do, a little bit more complicated, and we can talk about that later on. But dermal thickness can be impacted by different things, such as methylaminovoluminic acid, that can help enhance a little bit of type 1 collagen, or you could use a little bit of laser. So different things can impact dermal thickness, but that's a big thing that we take into consideration as well. And again, contributing to more bruises in the elderly. So here's a good example of the senile purpura that's very common. And I probably do get a referral, I would say maybe once every 6 weeks for a patient regarding these. And it's really quite easy to make. Sometimes there's a mistake. You kind of wonder if there's something else going on in a differential diagnosis. Is there a vasculitis going on? But the big thing is always observation and time. And that's the nice thing about dermatology. Give it 4 to 6 weeks, and you'll see a lot of these things change over time. But for a lot of the elderly, interestingly enough, when they come to see me, more of the concerns seem to be drawn towards the senile purpura compared to even a basal cell or squamous cell. Their focus is more on their forearms, their legs, their hands here. And again, that's due to the loss of the dermal collagen and elastin here and the changing in the wall thickness. And of course, we've got other changes here, the actinic keratoses here. So I know I put down the stats that at least 3 AKs for people over the age of 60, about 20% of the population. One thing to note is when you see an actinic keratosis, even if they have a single actinic keratosis on the face, there is likely 10 in the background that you can't visualize. So for an individual, even though they're presenting with a few, think about their face being plastered. So for example, a good rule of thumb is 1, you got 10, 50 for about 5 roughly here. And that can be just from simple scale that you feel. That's why it's always important to feel the skin, of course, after sanitizing here. Gloves are not a good substitute. You want to get the surface of your fingertips right on the skin just to brush over to feel if there's any actinic keratoses. They could be sometimes just simple erythema, and sometimes they're a combination of all 3 here. Now, with the actinic keratoses, of those that do have them, quite common, 7 to 17% is more of my rule of thumb that will develop into a squamous cell carcinoma. And, often a lot of people don't take them as serious, I think, as we should. But I have had patients get metastases from a squamous cell carcinomas and pass away from what we possibly could have prevented. Now, if that person has lived in the tropics, they're a Fitzpatrick type 1, 2, they've never used any photoprotection, they've got that genetic predisposition, and they're quite a challenge. We're catching up later in life. Yeah, I think it would be very good referral to make even to me or another GP derm to manage routinely. And I'll go in through the various managements that we have for that. The areas that are quite commonly impacted for the actinic keratoses, of course, the scalp of men. Many didn't wear hats in their youth, So that's a large area, of course, the face, the décollage area, the forearms, dorsum of the hands. Shins are also quite possible, but I often find for the shins and the feet to be impacted, again, more in women, various factors that we take into um, lifestyle as well. And I also find in Fitzpatrick type 1, more of the shins and the feet are more impacted there. Big population that we have to look at, the high-risk populations, would be the immunosuppressed here and transplant patients. They are very prone to squamous cell carcinomas, so we have to monitor them quite closely here. Various intervals in terms of monitoring. Some people recommend every 3 months. Some people recommend every 6 months. For me, I don't think it's a terrible idea every 3 months, especially in the elderly when they're already immunosuppressed. Here's another example of an actinic keratosis. As you can see on this gentleman's scalp, there's definitely a lot of macules, a lot of erythema. You've got what looks like on the left side there, more of a high-grade actinic keratosis. Actinic keratosis can come in different grades, grade 1, grade 2, grade 3. When we're going more on grade 3, we're on the spectrum to developing to squamous cell carcinoma. Do you need to worry about grading an actinic keratosis? No. The grading, what it often takes into consideration, it's taken into consideration the scale, thickness, the erythema. That's more of the pathology. We don't even see that in pathological reports in terms of grading of actinic keratosis. They either come back often as just AKs, high grade, and AKs we can often easily mistake even on biopsy for a squamous cell carcinoma. When I take that dermatoscope and I go around the area and I'm looking at the actinic keratosis, sometimes you see a little bit more of a pink centric area, some of these dermatoscopic features, and sometimes I biopsy them just to be extra cautious that they're not transforming into squamous cell carcinoma. Best case scenario and what I want to see always is just to come back as an actinic keratosis that can be managed through more easier means than surgery here. So treatment options, typically about 7 months. So say that we're treating a patient here who's completely covered with actinic keratosis on the face. Sunscreen, sunscreen, sunscreen will significantly reduce their risk of developing subsequent actinic keratosis. But has the damage also already been done? Yes, it has. Can they still develop actinic keratosis even after we treat them and we apply them routine sunscreen day after day? Yes. Depends that accumulated damage that they had throughout the lifetime. Cryotherapy often has a range of effectiveness. I often say it's maybe about 50% effective. Now, the big thing that we have to take into consideration with cryotherapy, I've seen a range of different treatments. I've seen individuals spray an actinic keratosis and apply gentle pressure with their finger to reduce the freezing at the point. But what's critical for cryotherapy is that freezing ball, that depth, and it has to be maintained for 10 to 15 seconds. I would say even 15 seconds is quite reasonable. But especially in our elderly population, we have to be careful because the longer the treatment, the more likely we're going to have complications. And complications are more likely to happen at specific sites in the body. So, for example, I am often reluctant doing a treatment more than 5 seconds on the shins of an elderly individual, just because there's a risk of ulcer formation. Ulcer formation, then we have a risk of infection, then we have wound care coming in routinely, and it's going to be taking sometimes several months for that to heal. So another thing that's always important for the elderly population is just informing them or their caregivers, their family members, of all the different possibilities, just because they're more likely to have a more generous response in terms of that ulceration as well. Let's see. So, oh, sorry, any questions here? I'll just continue. Let's see. There we go. Efidex. Now, we can use Efidex for treatment, of course, of the actinic keratoses. I often like to reserve it more for severe ones in localized areas. So if they've got severe actinic keratoses, and I would say more in the medium to the high grade, they're located on the ear, for example, maybe a localized patch on the scalp. My treatment will vary based off the patient, taking into consideration if they've had Efidex in the past, how close the treatment was to the Efidex that they've had in the past if they've had it. If you've had a patient, for example, go on Efidex for the face, and I've seen them then have it on a forearm, and then I've seen it on the leg, all in a time span of 6 months, and I've seen it prescribed upwards of 3 to 4 weeks for that duration, the risk of side effects are greatly increased. And those side effects that I've seen happen would be more like the flu-like symptoms, the hair loss. It's a toll on the individual, and I do like to reserve the Efidex, if at all possible. I have seen skin infections happen from Efidex, and if that happens, and sometimes it's hard to tell with the Efidex. Is the Efidex causing the skin infection, or is this just the exaggerated treatment response? Both are possibilities. Take a swab, send it off, and then you'll have your answer if you need to start them on Keflex. Based off my experience, 1 in 3 may, for an over-exaggerated response from Efidex, might have a skin infection. How do we reduce risk of that skin infection? Reduce contact to the site. So if a patient has Efidex being applied to the scalp, just ensure that the patient is not applying a hat to the site. We just don't want it to get sweaty, create a moist environment, don't want to introduce infection to the site. Say the patient has it applied around the nose area. Are they wearing glasses? Well, if they have an exaggerated response around the eyes, the risk of them having an infection might actually increase. So it's, or even around the ears, it's around the preauricular area where their glasses are coming into contact with. So different things to consider there for potential side effects. Treatment duration, there's really no hard and fast rule, but some people only tolerate once a day. Some people tolerate twice a day. If I'm going off more of my treatment, my guidelines, what I was taught through my curriculum, it's generally 3 to 4 based off our Cardiff guidelines. But of course, the longer that you do it, the more likely they're going to get side effects again. Maybe they only will tolerate it for 1 to 2 weeks. If that's all they're tolerating, even after you apply hydrocortisone to the site to reduce the pain, and the hydrocortisone won't reduce the effectiveness of the Efidex. That's actually one common question I get from people. The hydrocortisone will not reduce the effect. It's going to reduce a little bit of inflammation, but you're still getting the desired effect there. And the hydrocortisone is not working to stop it. Monitor the patient then, over the next 2 months, 3 months, reassess the patient. If it's still there, you could consider that or alternative treatments. Now, salicylic acid can also be used as an alternative. I've seen diclofenac, interesting. That one's actually in the research used. Have I personally used it for actinic keratoses? Not so much. And the reason why I haven't used diclofenac for actinic keratoses is you have to use it for 90 days straight. And compliance is a huge issue, especially if we're talking with our elderly population. You need to be doing it on a daily basis here. And the effect is mixed on that one. I would say maybe around 50 to 70%. But the compliance is huge in taking it for 3 months. So that one I haven't included in the notes here just because it's not part of my treatment regimen. Now, another thing that we can use for actinic keratoses is methylaminoaminic acid, or METVIX. This one is not used a lot in the US. It's becoming a lot more useful here in Canada, and particularly in Europe. They're the leaders right now, and they have been for the past 15 years, using photodynamic therapy for METVIX for actinic keratoses. Now, this one is great. It's great for, I would say, mild to moderate, just to prevent the patient from progressing to the severe or the high-grade actinic keratoses. And it has numerous benefits. Not only with actinic keratoses, there's other things that we can use for off-label usage as well, but that one is getting more and more research into the areas. Some studies are being done on it right now for possible acne usage, not really relevant to the elderly. There's research being done on it right now for superficial basal cell carcinoma in situ, but there's not sufficient literature right now to actually use it just for that right now. How this particular medication works, I've seen a couple patients get the prescription, pick it up from the pharmacy. Never, ever recommend it, just because this particular medication is incredibly temperature sensitive. So as soon as it comes in, it's refrigerated. It cannot be exposed, I would say, to normal room temperatures for more than 20 minutes at most here. What I do is I often apply this cream, again, after assessing the patient, to the face. That's the most common area, or scalp. And there's different ways that you can do it. You can send the patient outside for about, if we go by treatment guidelines, 3 hours is recommended. And the patient typically has to be exposed to temperatures greater than 10 degrees Celsius, and it has to be sunny outside. So that's a little bit more challenging time here in Victoria. If we're in a different environment, it works, but I like to reserve the daylight therapy more from the months of April through late September is quite reasonable here. And they have to, again, be outside for 3 hours. There's a lot of research changing on this medication to even gentle photodynamic therapy, where applying the cream for even 30 minutes will be quite effective for the patient. And again, just going out in the sunlight. The nice thing about this medication is minimal side effects when exposed to daylight. And if those side effects do happen, upwards of 7 days. What do I see in terms of a spectrum? On the mild end, I might see some flaking. I might see some dry skin, of course, after the treatment for 48 hours. As we get to more of the severe spots, the moderate grade actinic keratoses, those may get a little bit more of an exaggerated response. They could get blister formation. They could sometimes bleed a little bit at the site, but I don't see anything last often greater than 7 days. There is a slight risk of infection, and I have treated one patient for an infection off this. Again, the site, they were wearing their glasses on, and they introduced an infection at the site. It was raw. Nice thing about Metfix also compared to the Effidex. Effidex will possibly damage the surrounding skin. The Metvix focuses its treatment on the actinic keratoses themselves. So anything that's precancerous or even a superficial basal cell carcinoma is another indication for it. And how it works is through porphyrin activation. The porphyrins basically cause cells to self-destruct in the area, I tell the patients, and I reassess them in about 3 months' time. Nice added benefit from the for the patient as well. They can also get an improvement in their type 1 collagen. Some patients even see an improvement in fine lines and wrinkles. In terms of effectiveness, I would say it's anywhere from 70 to 88%. Again, there's different treatment or different various factors that impact the effect. So if a patient, for example, has a high-grade actinic keratosis or something that's very keratotic, I like to curette it, get it right to the base, and then it will be effective for the patient. So curetting sometimes for patients will make a difference. But interestingly enough, that's why I've seen clinically, there is some upcoming research that is suggesting that it may have an effect that goes deeper. I've only been doing Metvix here for the past year, so long-term follow-up will show more for me. And more as I see patients in follow-up, we'll see if the high grades have a long-term benefit as well. Downside, this is not covered by MSP. Price range in Victoria, there's a large spectrum for price range. anywhere from about $750 to about $1,200 per treatment of Metvix. Is it covered by plans? I would say it depends on the plan that the patient has. Sometimes yes, sometimes no. Now to the second portion of the treatment for the actinic keratoses here for Metvix. What do we do for patients that have a lot of actinic keratoses during the winter months? Or what if they have a superficial basal cell carcinoma in the winter months? What can we do? Red light therapy is done for that. Now, the red light is just not like one of those simple red light devices that you can get on Amazon, a low infrared, nothing like that. This is actually a really intense device here, and you definitely need protective glasses in the room when you go in. This light activates the medication. It's shined on each quadrant for 8 minutes total. For the actinic keratoses, 8 minutes on a single treatment. That's all that needs to be done. So maybe 8 minutes here, 8 minutes here, and if we're doing the scalp, 8 minutes here. Pain is variable for the patient. It's anywhere from 0 to an 8 out of 10 for some patients. But it's a discussion with them if they like this path. Would you choose to go for pain for about 8 minutes, or do you potentially want to have pain for 3 to 4 weeks from the effects of Epidex? So it's kind of a toss-up in the air what the patient wants. Is there anything that we do to treat the pain? They can take an aspirin before, they can take an NSAID before, not really going to change anything. And oh, sorry, another common question people often have for photodynamic therapy before we do it. Do I photosensitize them with a topical or oral retinoid before? Not for actinic keratoses and not for superficial basal cell carcinomas. We're talking acne, yes, we'll do a photosensitizer, topical tretinoin, but not if we're doing any oral treatment here. Yeah, so if the patient does have a lot of pain, I do have to stop it. My population who I'm doing this on right now, a lot of people in their 60s, 70s, and 80s right now are the ones that are kind of the prime candidates. Can I do it in a younger demographic? Of course, yes. Older demographic? Yes, of course. In terms of the long-term care population, if they have someone, a caregiver that would be able to bring them into office and then I can use the Actilamp in office, yes, I can treat them in office. It just takes about 3 hours of their time, maybe actually save a morning for that. And let's shift to the next one here. I'm just going to make sure I'm good for time. Just going really quickly here. Squamous cell carcinomas. So the precursors here. And what always want to prevent is that invasion of the epidermis into the dermis here. And most common locations that we've got here, face, legs, and I re-emphasize legs here just because it's quite common down there. The nodules can have telangiectasia. You can see ulceration in them. Sometimes a basal cell carcinoma is up in the differential as well. You can get variations in the squamous cell carcinomas. Often they're not pigmented, but there's a very small portion that could have some pigment in them. The metastases, they can go to lung, liver. That's why I want to treat them early on. Now, you can also get a cutaneous horn. That's exactly what it sounds like. A little horn that appears. It can be on the ear, it can be on the nose, on the face, scalp. And at the base of it, we can get some squamous cell changes going on. So it may not just be a high-grade actinic keratosis. At the base, it could be a squamous cell carcinoma here. I might have a picture on the later slide we'll see here, unless it got deleted. Any question of a doubt, always just biopsy, just the safest way to go. Now, risk factors for squamous cell carcinomas, this is where history is important for patients. Arsenic exposure, so if a patient has been living in the community and they've been exposed to long-term arsenic in the wells, farm patients often, that's another population, especially from the well water, arsenic. Does the patient have a very high seafood diet and has an excessive amount of shrimp? All are risk factors, interestingly enough, HPV transformation, X-ray exposure. So are we talking about a patient that's a pilot, stewardess, that is constantly going through X-rays at airports? Yes, they do pose a potential risk over a period of time. And then you add on the additional radiation for pilots and stewardesses on planes that get up there. So check what the patient's occupation was earlier in life, and that might also raise a clue to what they've got going on. Different carcinogens that they've been exposed to. So did the patient work in construction? Were they exposed to tar chronically? That would also increase their risk. I often see a lot of squamous cell carcinoma in about 60, 70-year-olds who worked in construction earlier in life. And last thing to note, I'll put down chronic heat injury, but chronic ulcers. Chronic ulcers do have a potential to transform into a malignancy. So often when I do a biopsy I always actually biopsy a chronic ulcer, no matter what it is, and I want that rim biopsied. Pathology likes to see a 5 mm punch biopsy done. And that sufficient tissue should be enough to send them off for the pathologist here. Now, often when it comes to ulcer management, for a squamous cell carcinoma on the shins, on the feet, I myself will refer off to plastic surgery, or even, generally plastic surgery here, just because patients may require a graft. You have poor circulation in the elderly, in the lower extremities, increased risk of infection, and they've often got that peripheral edema there. So it's always good to have plastic surgery in the pocket as well. So put down surgical excision. That's the most effective treatment. You're looking anywhere about 94 to 98% effectiveness, depending on the surgeon there. Rarely do I like to say 100%. Only time I often say we're getting upwards of 99% is if we're doing a Mohs procedure, and we don't have any Mohs surgeons here on the island. Margins, minimum of 5 mm are good when we get the area. Again, certain areas often want grafting. Discuss that here. Now, the squamous cell carcinomas in situ, Bowen's disease, these are these erythematous scaly plaques, well circumscribed. The morphology is quite key when describing these, and often characteristic. How do we differentiate an SCC in situ from, for example, maybe a superficial basal cell carcinoma, because both are in a differential diagnosis there. Same with SCC invasive in these locations. Biopsy, that's the best way to differentiate it here. But dermoscopy will also give you some features as well. Dermoscopy is only 40 to 70% effective, depending on the user. So there's quite a variability on that one. Dermoscopic features that I'm looking for an SCC in situ. Sometimes we can see coiled vessels, pinpoint vessels. I can see pink eccentric areas here. We get a low yellow scale. Those are more of the dermoscopic features that we would see. How would I differentiate that one from a dermoscopic feature of a superficial basal cell carcinoma? I would be looking a little bit more around the rim, in the periphery there. So a lot of different features, and that's where that dermoscopy training is quite essential, but not often available here. Treatment for SCC in situs, various different treatments. We can do Effudex. I would say Effudex, if we are looking at a treatment for that, twice a day, 4 weeks. I wouldn't do much less. Will they tolerate it? Questionable. Effectiveness, we're looking at about 40 to 50% effective rates in treatments for an SCC in situ. Other treatments that we can do for that, sometimes you can do a little cryo for the Effudex, but again, that raises your risk of complications as well. The Metvix, but again, that one is being more researched in the SCC in situ right now, and I don't feel comfortable right now for an off-label usage for it. So we go down to surgical excision often for this. Basal cell carcinomas, very, very common, and often you'll see 2, 3 on an individual. Risk factors for basal cell carcinomas: sun exposure. That's your greatest risk factor. One of the common questions I get from patients is, did I get this from my mother, father? And they're convinced that there's a hereditary component. No, lifestyle. This is a lot of the extrinsic and intrinsic factors that lead to the development of basal cell carcinomas. Morphological description, classic. You see that heaped up rolling rim. You get the telangiectasia. The telangiectasia, which are the dilated blood vessels, it often crosses the crown of it. A big one that's often a differential diagnosis here for the basal cell carcinomas are sebaceous hyperplasias. And the sebaceous hyperplasia has the telangiectasia going more in a crown distribution. You also see more of a lobulated yellow appearance on dermoscopy as well. Again, when in doubt, biopsy it, or I'm more than happy to assess the patient here with dermoscopy. Sometimes I'm fooled and it comes back as a sebaceous hyperplasia, but always want to be careful. There's different types of basal cell carcinomas out there, low risk and high risk basal cell carcinomas. The ones I would say that are more low risk would be a little bit more of the superficial. The ones that are more high risk would be more of the sclerosing, morphic, the infiltrating basal cell carcinomas. Those are a little bit more high risk. Locations that are a little bit more high risk, I would say, would be the T-zones. And when I say high risk, I mean more high risk in terms of not having a good clearance after surgical removal or other treatments and requiring subsequent removals in the future. So we're looking around the periorbital regions, we're looking around the ears, nose, and that's areas that are more likely to have chronic damage as well from a basal cell carcinoma here. We've got some stats: 70% base, 30% on the trunk, and again, they can ulcerate here. Again, dermoscopy is important here. Dermoscopic features that I would be looking for: that micro ulcerations. You can get a sticky fiber sign as well. So that's where they're actually getting some fibers from the clothes that stick to the ulceration on the basal cell carcinoma. The telangiectasia is quite key though from these. Treatment options. Okay, so we've got radiation therapy. I like that, but there's often a challenge, especially with wait times to get into the rad-onc treatment offices. So I'm working right now with a colleague to try and streamline that, but we're getting a little pushback. It's not the easiest. So that leaves us with more different surgical removals. Ones that I personally feel comfortable removing, I'll sometimes do them on the face, forehead, cheek, temple. If they're quite large, I'll send them off to the plastic surgeon. If they're on the ear, I like to refer them to a plastic surgeon, scalp plastic surgeon, neck down, depending on the legs and their various risk factors, might even do legs as well. So I'm happy to do that in office. Surgical excision, again, for basal cell carcinomas, we've got a range of effectiveness. It can be anywhere from 94 to 98% effective, again, depending on the who's removing it. Mole surgery is the best way to do it. Again, we don't have a mole surgeon on the island. We've only got a couple on the mainland. And the wait list right now for that is about 1.5 to 2 years, I believe, for a mole surgery. If the patient wants to pay privately and go somewhere in Washington State, that's another option that I would offer a patient, but it does take some time here. Superficial basal cell carcinomas, as you notice in the picture, it's got more of that pearly rim to it, which differentiates it a little bit more from a squamous cell carcinoma in situ. Biopsy is still very important, and I do it every time before I commence any treatment. Where do I see these? Very often on the back. And different treatment options for a patient. So we can do electrodesiccation and curettage. That treatment it's nice, it's reasonable. You may have anywhere from about 85 to 95% effectiveness in treatment for that. And that's essentially where I put infiltrate some xylocaine into the site. And then I do some electrocautery on top, curette it, electrocautery, curette for about 3 to 5 cycles. But there is a risk of recurrence, and I tell patients that. There's also risks, various risks of infection. I like to put a patient on an antibiotic after and essentially treat them as a burn victim after, just because it is very invasive and you're losing that barrier that's protecting the patient from those organisms from entering there. So that's one option that we've got. Another option, you can do the MET-Vix. That takes about 2 treatment rounds. In terms of effectiveness, you're looking about 88% effectiveness in treating with the MET-Vix here. Treatment rounds are 7 days apart. And again, that can be done in 2 different methods. That can be done either through the daylight exposure where they go outside. It's nice. They don't really experience pain when I send them outside. Sometimes the patients do, not really. Or I can do the red light treatment inside. And again, 7 days apart. Follow up 3 months time. Another treatment option for the superficial basal cell carcinomas, just to cut it out. And that one you're looking at about 94% effective in treatment here. It is important to note that these can also be a cause of morbidity, and there's rare cases of mortality for patients. So it is important to take everything seriously here. Efidex, I don't really like treating it, but with Efidex, for some patients who are palliative, end stage, I wouldn't do any treatment whatsoever, to be perfectly honest. So certain physicians may do the Efidex. If you are going to do the Efidex, do it then twice a day for 4 weeks time. Follow up 3 months time, and then do another follow up later that year just to make sure that it hasn't returned. Important at the follow up. This is where I again recommend dermoscopy, just to make sure that there's no telangiectasia that's reappeared at the site. It can be quite subtle. Adverse drug eruptions. So this is critical, I would say, for anyone young to old. And polypharmacy is quite a common issue here. I've come across that myself, and I've made that mistake myself in my past family practice as well. So it's important to analyze every single medication the patient is on. The elderly do have a significant increased risk of adverse drug eruptions. We've got altered pharmacodynamics and kinetics here, change in organ reserve, kidney and liver function, and you have to assess accordingly here. Take that history from the patient. Do they have chronic renal failure? Do they have fatty liver disease? Do they have cirrhosis? Anything else going on? So history is very critical when we first assess a patient with a rash here. Need a precise list of medications. And that's what's great about long-term care. Everything is often in the hospital. I'm asking my patients when they come in, just because a lot of elderly patients, when they come into my office, they forget their medications and not everyone has a list. So I often ask or always ask my secretaries to provide them with an intake form so that I'm able to review what medications that they're on here. It is so important to review everything from over-the-counter medications to even herbals. So are they on fish oil supplements? Fish oil supplements might photosensitize them more. Are they on St. John's wort? That could photosensitize them more. So getting a good complete list of medications is really important. When a patient does have a rash, of course, it's always important to get that temporal relationship when they've taken the medication and when the adverse reaction has appeared. The challenge I often find with the elderly population is their history. So this is where chatting with a caregiver or documentation in terms of care aides, nurses, physicians, this is where it's quite critical when the patient first took the medication. Just that relationship, often I see an adverse drug reaction happening in about 1 to 3 weeks here. My approach, what I like to do if we're starting a patient on a medication, just do one at a time, just because the elderly population, given that they do have a high risk of adverse drug reactions, if we're starting, for example, a patient on bisoprolol and we're dropping them down from their clopidogrel to their ASA, then I still would just say, start with the bisoprolol, wait 4 to 6 weeks, then start the ASA. Some of these common over-the-counter medications as well can create an adverse drug reaction here. So that's what's really important. Take everything serious in this population when starting something new. Let's see. Morphology is important. So we've got our morbilliform rashes here. And honestly, though, an adverse drug reaction can present in almost any way. I've seen it present in psoriaform reactions. I've seen, for example, a patient on beta blockers develop a psoriasis-like rash, and I did a low biopsy on it. We've seen some changes that were consistent more with an adverse drug reaction. Discontinued the medication. 6 weeks, the rash was gone. We had our answer. But this is where it's really important. I don't stop medications myself just because I believe it's important for the family doctor or the specialist that's initiated the medication for the patient to stop the medication. I provide the advice to stop the medication. And if they were started on multiple drugs at once, I say, if you can, stop everything for 4 weeks, stop everything for 4 weeks and see if the rash clears. Often do the rash clears? Yeah, they often do clear. Antibiotics, they are a huge culprit here. So if a patient was started on an antibiotic within the last 1 to 3 weeks, you can probably safely assume that the antibiotic caused the adverse drug reaction, and that's resulting in the rash that the patient's presenting with. So would I stop the antibiotic and any other medications that were started at the same time? If I could, yes, I would. But if those medications, for example, they just had a STEMI, they were placed on some beta blockers, they were placed on clopidogrel, anything else that they can't stop, and also an antibiotic, and you can't stop those, just stop the antibiotic and then save the other ones. But if you can stop everything, please do. Now, this is an example of a fixed drug eruption that can happen in any population. They're quite interesting, quite unique, and morphology again is key here. Well-circumscribed area here, and you get more of a hyperpigmentation. It almost looks a little bit like a bruise, but it's that bruise that is not going away in a patient. There's different locations that you can see it. You can see it on the trunk, you can see it on the leg. Oddly enough, fixed drug eruptions can also occur on the penis. So very odd locations that they can manifest in. They can present in different sizes. You can see anywhere from 1 centimeter. I've seen upwards of 2 centimeters, fixed drug eruptions here. So just to break down some major offenders that we've got going on here. Again, already mentioned antibiotics were one of the worst culprits, upwards of 40% in terms of adverse drug eruptions. Anti-inflammatories, analgesics are huge. Is a patient on Dilaudid? Are they on anything like that? Is a patient on a leave? So check if they're on NSAIDs. If they're on NSAIDs, stop them. A lot of patients don't think NSAIDs are medications, and you have to be detailed in your history and ask them, Franco, are you on aspirin? Are you on Advil? Anything. And even a generic versus brand, you have elderly patients that may not know one versus another. So ask it in different ways. Contrast media. So has a patient just recently been sent for a CT scan, and have they developed a rash? I would say contrast media, more about 24, 48 hours, but yes, you can see it upwards of a week or a little bit longer after as well, but that one's a little bit more earlier on in the course. Now, just back to the basics here, it can be allergic response to the drug itself, a response to the metabolite of the drug, or a non-immune reaction. So different factors could be impacting here, something that's not separable from a desired response. So when we prescribe, what I mean by that is we're prescribing a medication here. Say I'm prescribing minoxidil, well, that was more in the past. In the past, we prescribed minoxidil for hypertension. Now, in the past, minoxidil prescribed for hypertension also had an adverse drug effect of causing a patient to become extremely hairy all over the body. Now, when we apply minoxidil, now topically just to the scalp, we get hair growth. So that is actually an adverse effect from the drug, but it's also a desired response. Now we've got other things. We've got delayed toxicity. So I mentioned earlier, arsenic exposure could lead to a squamous cell carcinoma presentation in the elderly, or it could be just a direct immediate release of the mast cell mediators. And that could be something that's resulting in angioedema. And I mentioned earlier that the contrast media, within 24 hours, 48 hours, you often see a response. That's that direct response. That's why it's happening quite early on. Immunological. So we've got our med school, nursing school basics here, our type 1, type 2, type 3, type 4. It's very important, I think, just to review them all. Our type 1, our IgE dependent ones. And that's where you give a patient, for example, penicillin, they're getting an anaphylactic response here. Could also be an urticarial response as well. So on the left here, I do have a picture. This one's more cytotoxic, thrombocytopenia here. That's resulting as a response to the drug. This one would be non-blanchable. Type 3, we've got our immune complex here. And that's where a patient may have serum sickness, our immune complex vasculitis. Type 4 cell-mediated lichenoid erythema multiforme, Stevens-Johnson syndrome. If a patient does develop a type 4 response to erythema multiforme, particularly Stevens-Johnson's, I would say, or 10, that's where you want to get not GP derm, that's where you want to get dermatology on call and possibly ICU. A little bit more into the drug-induced urticaria here. So one thing to be cautious, we're in vaccine season here right now. So did a patient get a reaction in form of urticaria? So urticaria would be wheals on the body. Wheals are kind of these red raised spots that disappear or migrate over 24 hours here. And that can happen in response to penicillins, cephalosporins, sulfas, ACE inhibitors, and NSAIDs are big culprits. And I highlighted them here just because we do see this often in the geriatric population. Do we see biologics? Not often in our elderly population, particularly long-term care, often past that point. Radio contrast media would be another one here. Aspirin. I have seen a patient just recently here a couple months ago, severe desquamation, and it turns out that their adverse event was due to aspirin here. Again, they were just started on 2 new medications. One of the medications was a very highly unlikely culprit here, but they couldn't be taken off of it. Stopped the aspirin. It took about 4 weeks for the patient to start to improve. We did a little bit of prednisone on the route. The prednisone did help with the overall reaction for the patient, but aspirin is a big one here. So again, ask everyone if they were just put on aspirin or if they're taking it and you don't know about it. So here's a good example of a maculopapular rash. They're often very itchy, symmetrical and widespread here. Big thing to note, the difference between a viral rash. A viral rash will often start on the face, where often I see more of a drug-induced rash start on the trunk, and it often spares the face. The example of the patient that I had a couple back in late September, October here, classic example where it started on the trunk and spared the face. Again, pruritus is very common with a drug-induced rash. Viral rash, not as much, but still possible. We chatted about several days, up to 3 weeks here. other rashes that can appear drug-induced. Allopurinol is a very common culprit as well. Phenytoin, don't see that too much, but some patients, gold, we don't worry about too much in the elderly population here. I put down fades 1 to 2 weeks after stopping the drug. I would say a little bit more on the 2-week side and just starting to fade. Give it 3 to 4 weeks. Another cool one here. I tried to put a picture of the lichen planus like it didn't stick in here, but uncommon. And often they just resemble an idiopathic lichenoid eruption, or they can be eczematous, rhiiform. Histology is quite important here, and taking a biopsy will still point on histology towards a drug-induced eruption here. Common culprits for those, thiazide diuretics. Has the patient been placed on hydrochlorothiazide? Statins, also another culprit. Of course, I'm going to leave this more up to geriatricians, long-term care physicians here, but often a patient doesn't need to be on a statin or initiated past the age of 80. So if they can be off of that, that would reduce the risk. And if they were recently started it, might be a good idea to stop that one when trying to rule out adverse drug reactions here. Always like to throw in a gory picture here, just to regain interest a little bit later in the presentation here. Good example of Stevens-Johnson syndrome, progressing to toxic epidermal necrolysis here. This particular one impacts mucous membranes. You could be bleeding out from your eyes, mouth, pretty much any of the mucous membranes here. Everything, it's like a burn victim, just falling off the body here. Again, outside my scope of practice, get ICU involved, stat. But most important thing, they're sloughing skin, stop any medication that they've recently started here. That's the first thing that you do. Good example of what I just mentioned here. Most changes to her oral mucosa here, and as well as her conjunctiva here. We're getting our severe ulcerations, erosions, blistering, epidermal sloughing here. And I mentioned that there is a spectrum here of body surface area that's involved. Drugs account again here, 85% for Stevens-Johnson syndrome here. Big offender often is allopurinol, but consider any possible medication. So also on the list here, we've got our antibiotics. We've got our anticonvulsants, sulfa, NSAIDs, and barbiturates. Next, if you've noticed, there's a reoccurring theme here. Antibiotics, sulfa is a big culprit, NSAIDs. NSAIDs are reoccurring in terms of adverse drug reactions. Mentioned to stop the medication, that's the most important step here. And of course, call the burn unit or ICU. Now, drug-induced pigmentation. This one's quite interesting here. And it's through altered melanin synthesis. It could also be some post-inflammatory hyperpigmentation or deposition of the medication itself into the skin. Good example would be from minocycline. Patient might get more of a gray-blue tinge that's irreversible to their skin. Often appears on their forehead, cheeks, and that would be being on the drug often. I would say, if the patient's been on it more than a year, but if you're noticing different guidelines, I notice in Canada, we often use the minocycline still. Noticing in terms of treatment recommendations in the UK, they don't recommend minocycline. That's a little bit more outside of our geriatric population right now, but just something worth mentioning too. I have a little list here of the different medications here. Again, we don't really see some of these medications used too frequently. The ones that would be a little bit more common would be the minocycline, the amiodarone. The amiodarone is quite interesting. You take the medication and then you go into a light exposed area, and that will actually lead to pigmentary changes as well. They're all contraceptives. That's not relevant to our population here in the elderly here. One thing to note, topical steroids can lead to pigmentary changes in the patient as well here. So we can get a variation of hypo or hyperpigmentation. Now, we can get pityriasis-like eruptions, and sometimes we just jump to the conclusion that it's not drug-induced. Again, check with the patient, especially if they're more in their 40s, 50s, 60s, 70s, they're presenting with a pityriasis eruption. Have they been placed on an ACE inhibitor or a PPI? These two in particular, the omeprazole and the captopril, those I find are, based off the literature, the biggest offenders here. I see more of the pantoprazole, rabeprazole prescribed, not so as much, but take that into consideration if they're getting a pityriasis-like eruption here. Again, discontinue the medication. The pityriasis-like eruption, that's a little bit trickier. You discontinue the medication, takes about 4 to 6 weeks. Was that pityriasis or was that the medication? Who knows? What do you do in that particular scenario? Reinitiate the medication after they've been off of it. I like to stay off of it for about 3 months' time. Restart it. If they develop a pityriasis-like eruption again, then we've got our diagnosis here. Irritant dermatitis. This one is interesting here from, especially in our elderly population, long-term care population in particular. If the patient is in bed for a prolonged period of time and say they're on laxatives and they're not being changed frequently enough here, exposure to that laxative actually in their stool exposed to the skin could be causing a change in their skin here. And you notice it's quite circumscribed. You've got nice delineated borders here, and it's in the area itself. Now, could it be from other possibilities as well? It could also be from urine, not being changed frequently, also from that. It could be from if they are wearing underwear and they're not in any diapers there, it could be from a detergent that they're exposed to as well. So always take into consideration detergents and ask every single patient if they're on a detergent. And if they're at home for an elderly population, it doesn't apply so much to the long-term care population, but elderly that are at home, just have them change to like a good Kirkland brand, something basic, no fragrance, simple, and in about 4 to 6 weeks, we should be able to see this reversed. But take the other things such as laxatives into consideration here. Now, threw in a little added one here, pruritus in the elderly. Huge impact on quality of life here. And this is a very challenging one. Elderly population, I'd say every other man or woman comes in with pruritus and they're asking what I can do for them for that. Chronic pruritus, anything chronic seems always defined more than 6 weeks' time. That goes for chronic pruritus as well here. We don't often get a cause. And often it's just the extrinsic and intrinsic factors of aging as well. I mentioned earlier on in the presentation, the fatty acid depletion. And the fatty acid depletion is often a common cause for that. You've got changes to the epidermis dermis. You get a leaky barrier, moisture's coming out. And that's a big cause for pruritus in the elderly here. But there's other things that we have to take into consideration here. And some of those are some rare but more serious disorders. Bullous pemphigoid is a good example. I had a patient that was presenting with about 6 to 9 months of pruritus here, and something just was fishy for me. He was 60 years old, and he did have a very mild rash starting to develop, but for about 6 months prior, nothing present. Biopsy proved that he had bullous pemphigoid, and we treated him accordingly. Now, a common one that we have, eczema craquelé, if left untreated here in the elderly, and it looks just like it sounds. The skin is cracking, and we see that often in wintertime in patients. More in drier environments. So if a patient is, for example, in Alberta, one of the prairie provinces, or just moving from there, and they've just been placed here in Victoria, that's a possibility. But it's still common here. Impacts the shins, the back, upper arms, and it's quite common in the long-term care population. Now, the biggest thing that we can do to get the pruritus under control is frequent application of emollients. You can use different things. You can order an E4I, E45. You can use Vaseline, Glaxo base. You can use Aveeno. You can even go as simple as using lard, as long as you're creating a moisture barrier. The big issue with the elderly population, they want to be very cautious with their funds and their finances. So what I find is they're only applying a very thin layer and they're not doing it frequent enough. And then they come in and they want a medication. It's important to have the patient come in, ask them to bring in the medication, and have them show you how they're applying the medication. Are they applying a very thin layer? Are they applying a thick layer? If it's thin, we have an answer. Is the patient applying it 3 times a day? Twice a day, absolute minimum, 3 times a day. And if you can even doing more frequent, that's great. And another way that you could actually do to ensure compliance for the patient, have them do a little chart and document every time that they're applying it. And make sure that they're just not applying it to a small itchy spot, but all over. So if it's on the trunk, have their caregiver or partner apply to the entire trunk. That way we get better control of the pruritus as well. And again, everything is equal. Just get it on them. That's the most important thing. If there is no rash, more investigation should be pursued here. Physical examination is always important. I do like to get a basic CBC, ferritin, renal function, and liver function tests. Chest x-ray is great. Just rule out any lymphomas. That's a cause of pruritus and sometimes a rash as well. So getting a good picture, ruling out anything the weird and wonderful is also important here. A good drug history is important. So I want to, again, check any diabetic medications that they're on. Some diabetic medications, metformin, Ozempic, these different ones can be a common cause of pruritus. Antibiotics, very common cause, and the antihypertensives. Now, differential diagnosis, something to always keep in mind here. If they don't have, again, a visible rash on their body, consider that's why we're getting that LFT. We want to make sure that there's no cholestasis going on here. Renal functions, just rule out uremia. Again, malignancy, that was mentioned though through the chest x-ray. Pruritus, one thing I do want to mention as well. Often you do see a visible rash with this one though, but a very intensely pruritic rash that's not amenable often to even topical steroids. I always worry about mycosis fungoides, cutaneous T-cell lymphoma. One of the big things that we often do is we do a biopsy, send it off, and it comes back negative. But if something's not right, they're not responding to their medication, poor response even to prednisone, extreme intense pruritus with a rash, a little sidetrack here. Sometimes we need to do 2 or even 3 biopsies to confirm a mycosis fungoides. So don't get discouraged if the first one comes back negative. Infections, we've got endocrine disruption, neurogenic changes, disorders of iron metabolism, psychological, dementia, anxiety, or heart failure, just basic common pruritus of the elderly, and bolus disorders here. One also could mention is hematological, like a cutaneous porphyria cutanea tarda. Again, porphyria cutanea tarda, that would be more of a hematological one. Don't often see that one in the elderly here, but also should be on a differential here. Topical corticosteroids after emollients are applied. If you can, start low and then work your way up the steroid ladder in terms of potency. Again, the elderly already have thin skin, and we don't want to increase the risk of more senile purpura or any adverse events here. So if you can start with a hydrocortisone, 1%, 2.5%, then slowly build it up the ladder. Often, I've fallen victim to this in the past as well. I'm putting a patient on betamethasone valerate But often it's because the patient has already been trialed on lower strength steroids already. But be cautious when we're starting on a strong, intense steroid. And please don't give them clobetasol right off the bat, just because that one is quite intense. If we are prescribing steroids for the patient as well, be cautious what you're prescribing in what particular body part. So if you are doing a steroid for an elderly for pruritus, be careful if you're applying it to the axilla, the groin area, or the face. The increased moisture and occlusion in the axillary area, or even gluteal folds, groin, will increase the potency on its own of that topical steroid. So go for something low strength in those particular regions, and you can do something a little bit stronger on the trunk, on the legs there. Antihistamines, be cautious when prescribing them as well, just because there is research starting to indicate that there's an increased risk of dementia with prolonged usage. And in the elderly population, we can't really risk that much more there. Topical doxepin, not unreasonable to apply for the elderly population short term. And this, you have to be cautious though. Apply this in the evening time, but it does potentially make a patient a little bit more drowsy and could put them at increased risk of falls. So if you're prescribing this medication, take the whole patient into consideration. Do they have nocturia, frequent urination? Is the patient have mobility issues? Are they using a walker? So different things that we have to be careful with. Take into consideration some selective antidepressants here, and the venlafaxine. You can use duloxetine here. Again, start low, go slow with those medications here. Gabapentin, pregabalin as well. Elderly population, the phototherapy, doing UVB treatment can be of benefit for pruritus in the elderly. There is an issue with this particular one though, just because it does take quite a bit of time for the patient. For GP Derm, unfortunately, with the province, where I'm having an issue referring a patient off to the RHH therapy, but I can refer off to a colleague that does have a photo booth. Unfortunately, she's a colleague, but I'm more than happy to refer off to her for a UVB if they do have chronic pruritus as well, and can get them in probably within about 4 to 6 weeks' time. Now, phototherapy does require frequent treatments. I mentioned 3 treatments a week, and then that would be slowly decreased over time. So again, time is an issue, but it is covered by MSP. Lifestyle modifications, again, quite important. Take a look into their household. Do they have central heating? Can't really change or alter this one from long-term care facilities, but probably an issue here in Victoria, especially with a lot of the older buildings here. So don't jump just to the patient and blame them that they could be doing something wrong, or it's something from their health perspective that's leading to that. It could be something in the environment that's putting them at risk to develop this. Again, I mentioned stop all detergents, add on a humidifier here. Bathing, careful with bathing. Just hot baths will increase the risk of losing moisture and putting them at increased risk of pruritus as well. And in addition to baths, make sure that there's no fragrances in there, no soaps, anything that could cause irritation for the patient here. I do like to see the patient just have a short cold shower, pat dry, and just use a cotton towel. Patients often, especially the elderly population, have an altered sensation here, and they don't really note that their clothing could actually be an irritant for them. So wool, ask them if they are on wool, very common, especially in elderly population. Tell them that they have to stop wearing all wool and only wearing synthetics. They won't like you, but strongly advise, just because it is a big skin irritant. Again, mentioned emollients, I can't reinforce enough. Anything Vaseline, Glaxo base, very important here in reducing the pruritus. And that's everything here for today. If anyone has any questions, I'm happy to answer them now, or if you want to send them via email, and if it's something I can look up for you, more than happy to do so.
Thanks so much, Dr. Galas. So if anyone has any questions, please feel free to unmute yourself and ask away, please. Anyone have any comments or any queries related to dermatology and long-term care? Type them in the notes there, or feel free to unmute yourself.
Thank you, everyone. Yeah, if anyone has any questions whatsoever that might be burning after the presentation as well, feel free to email me. I'm more than happy.
Great. Well, if there are no questions, then we can probably end up a little bit early here. But thank you, Dr. Galas. That was a great presentation. Thank you so much for speaking to us tonight.
My pleasure. Thank you very much, Jessica, for having me here today.
Oh, looks like we do have one question now in the chat. I'm not sure if you can see that. Out of interest, what is your usual course of pemphigoid treatment? I'm not sure if I'm pronouncing that correctly.
So if we're talking about pemphigoid here, so doxycycline, like that one, combined with a topical steroid. And then I wean the patient off the doxycycline here and just use the topical steroid and then try weaning them off. If it comes back, then I reintroduce it. My pleasure.
Great. Well, thank you everyone for attending, and thank you again.
Thank you. Everyone have a great day.
Great night. Bye-bye.